Mistress Naomi Jeremiah, Permanent Secretary, Ministry of Mental Health, Wellness and Religious Affairs. Mr. Josh Hector, Director of Mental Health and Substance Abuse, Ministry of Mental Health, Wellness and Religious Affairs. Dr. Tereline Malcolm, Advisor on Non-Communicable Diseases at PAHO, who is online with us. Dr. Simatra and Mrs. Jasmine, our PAHO consultant on our mental health policy. Mr. Reynold Hewitt, our country representative for PAHO. Dr. Neil Chaitan, International Social and Skills Behavioral Modification Specialist. I am not seeing Dr. Burkhardt in the room. I'm not sure if he's online, but he's our psychiatric consultant at Mungi Hospital, our Health Services Administrator, Father Roland Mark, representatives from the Ministry of Education, the media, persons from within the Ministry of Mental Health. I want to welcome you and say good morning to each and every one of you this morning for participating and for us to continue to involve every sector within Grenada as we consult on finalizing our mental health policy and suicide action plan. This morning, before we get into the details of why we are here, I will call to the podium Father Mark to bless us.
Thank you very much, Mrs. St. Paul. Let's bow our heads in prayer. Gracious and ever-living God, we are grateful to you for life here this morning. We are grateful to you for taking our consultants safely across the world to Grenada and for us leaving our individual homes to be here. We offer unto you, Lord, this consultation. We offer you, dear Lord, as we continue to advocate through policies and legislation as it relates to suicide and mental illness. We pray, O God, that as we offer ourselves for discussion, as we pray, O Lord, to get a clearer understanding of the goals and objectives and how we can partner with our Ministry of Mental Health, Wellness and Religious Affairs, we offer this day to you. And may we find its success, the growth, as we seek to take this nation forward through education and policy. We ask all these through Christ our Lord. Amen.
Okay. So this morning is just one of the activities as part of the ministry strategy to help to ensure that we strengthen our mental health services across our nation. I think over the weekend we all would have heard what is happening out there affecting our men. And it is most fitting that what we are trying to do as it relates to strengthening our mental health services, we can see the importance just by looking at what would have happened over the past weekend. So the ministry is on a drive to ensure that the well-being of our nation is one of the things that is in the forefront of our governance. So to give us an overview of why we are here today, I called Mr. Josh Hector, our Director of Mental Health Services, to the podium.
Good morning, everyone. Pleasant good morning to the distinguished representatives from the Ministry of Education, partners, colleagues, ladies and gentlemen. I wish to thank you again for joining us as we continue the consultation process surrounding Grenada's national mental health policy and action plan, particularly in relation to suicide prevention and strengthening our national mental health response. Today's engagement builds on the valuable discussions and contributions shared on previous consultations. Your participation reflects the importance of cross-sector collaboration in shaping a mental health system that is responsive, inclusive, and aligned with the needs of our population, particularly our children and young people within the education system. So we are really moving forward and moving closer to finalizing the mental health policy. Therefore, we remained focused. And what is the goal? We remained focused on strengthening access to quality mental health care. That's one. Enhancing prevention and early intervention strategies. Two, improving mental health surveillance systems and building stronger national coordination around suicide prevention. The education sector remains a critical partner in this work. Schools and education systems often face the emotional, behavioral, and psychological challenges. This is the point at which these challenges emerge. Therefore, the role of educational institutions is essential in early identification, support, referral, and mental health promotion. And importantly, following the completion of this national mental health policy, we will also move forward to modernizing and updating the mental health legislation, which is much needed. That is to ensure that our legal framework reflects contemporary standards in mental health care, human rights, dignity, and protection. So we deeply appreciate the continued support provided by the Pan American Health Organization and, of course, by extension, our partners from the Center for Mental Health Law and Policy, India. Throughout this process, they have been holding our hands, so to speak, and so we are grateful. And of course, thank you to the participants from the Ministry of Education today. For the continued engagement, partnership, and commitment to strengthening the mental health and well-being across Grenada, we thank you for showing up, and we trust that you can give your comments, your feedback, because it is very important to hear from you. This will add value to the mental health policy as we approach finalization. Thank you very much.
Thank you, Mr. Hector, and I hope the participants are now a little bit clearer as to our objective for today. All right, so we now ask our Permanent Secretary to express appreciation to the participants and to give some brief remarks to you.
Thank you very much, Madam Masters of Ceremony. A pleasant good morning to all. Today is a happy day for us at the Ministry of Mental Health. Though we may be happy to push forward this policy on suicide prevention and mental health policy, our nation is at a critical junction. And I want to call out loud to our stakeholders to let them realize that the Ministry of Mental Health needs all on board. We see what is happening. We ask that you come together, collaborate. We want to recognize here with us today Mr. Josh Hector, the Director of Mental Health and Substance Use, Ms. Dr. Taraline Malcolm, who is the Advisor, Non-Communicable Disease, she's online. Dr. Samartha Pathar, he's one of the consultants from Pan American. We acknowledge his presence. Ms. Jasmine Callahan, consultant. Mr. Reynold Hewitt, country program specialist. Dr. Niels Chaitan, international social and skill behavior modification specialist. And also Father Edward Mark, who is also our health services administrator. I also recognize the team from the Ministry of Education. We are happy to have you, and we know that you have a lot to communicate and discuss here today with this dialogue. My staff at the Ministry of Mental Health, and together with the team at the media, one and all, welcome. It's no easy task to pull stakeholders together, but we are grateful for what's to be done. We're grateful for what's going to be disclosed here today. We noted that our consultation commenced a couple months ago as we met with all of our stakeholders on a broader base. We had the Ministry of Education, the Ministry of Social Development, the police, the prison, and the list goes on. This week is a high week for us. We commenced today with our first consultation with the Ministry of Education. Now, this consultation is with specific heads of division. We believe that we needed to meet with the persons who make decisions within the ministry. So we had asked for the PS and all other CEOs, assistant CEOs, and these other heads of departments to be here so that we can really flesh out what we have, where we are going, and what we need to get done in order for this policy to be implemented and successful. Now we see in our small Grenada that this policy will benefit each family. Now we know that Grenada is a small island developing state, and we know that there is something called stigma out there, that persons are afraid to source help. They're afraid to go at the primary level. Now we see here locally in Grenada that we have an issue in terms of our child and adolescent clinic. In fact, in 2025, the data have shown that at the beginning of 2025, our clinic was at 150. At the end of 2025, our clinic had moved from 150 to 300. It has doubled. And our stakeholders are not understanding that is us to come together to make a difference for our young boys, our youths, our children, the adults. We need to hold hands and understand it's a teamwork so that we can achieve this mission. Now, my heart aches me when I see young men go down with suicide. It's a very painful experience. And sometimes I wonder if you don't feel guilty, but I do feel guilty in some way or the other. Should I have done something more? Can our ministry should have reached out? Where is the system that young person went through? Where have the failures come from? And let us not take our heads and dip it in the sand and point fingers to no one. Let us stand up here and put our heads together and plan and design where we can collect these persons who have suicide ideation early so that we can make an impact and a change. And the statistics that we are seeing in 2026, this is already a record year for Grenada. This is already a record year. So I thank all my stakeholders this morning. I thank all those who come and realize that we can make a big difference with this policy. Can I get a round of applause? We can make a big difference with this suicide and mental health policy. Remember, the draft bill been there. That bill been there over 100 years now. And that is why we need to have the draft bill. That is why we need to have that bill amended, tweeted, and fitted for our time now. Now, this document, it will be the legal document that will shape the face of how we respond to our mentally ill. Remember, mental illness is just another illness. Persons always try to say it's some other, just as how we have diabetes and hypertension, and we have medication that you treat for your diabetes and your hypertension. But we have to realize that we have to treat our mentally ill with some level of professionalism and respect. And this is what we are lacking. But I'm happy for the work that my friends from Power, my consultants, let's give them a round of applause. They have stand the test of time and have delivered a well-rounded document for our ministry to work with. And I thank them dearly. I thank my director also, who labor day and night and day. And this week, we want real success because we are going to go in the community. We'll be moving to the community coming this week to have our consultation. We want to hear what our nation have to say. We want to hear from our men. We want to hear from our women. We want to hear from the youths this week. So my team here, we're going to be in St. Andrews. We're going to be in St. George's at different areas. I guess the moderator will advertise. And we're hoping that all will come out and support this worthy cause. So thank you and do enjoy the session here.
Thank you, P.S. Jeremiah. I don't think anyone could have said it better than her. So we move on to the rest of the program, and we now invite Dr. Tereline Malcolm, our advisor, to give some brief remarks.
Hi, good morning, everyone. Allow me to adopt the protocol already established. Thank you, Madam Chair. It is my pleasure on behalf of the Pan American Health Organization, the World Health Organization, to participate in this important stakeholder consultation with the Ministry of Education on Grenada's mental health and suicide prevention policy. I really wish to commend the Ministry of Mental Health for its leadership and for intentionally engaging the education sector as a critical partner in this process. I also bring greetings on behalf of Dr. Amalia Del Rego, the PAHO WHO representatives for Barbados and the Eastern Caribbean countries. She extends her commendations and best wishes for a successful consultation. So PAHO commends Grenada's commitment to strengthening its mental health system through policy and legislative reform. So across the Caribbean and the wider region of the Americas, countries are increasingly recognizing that the education sector plays a vital role in promoting mental health, preventing suicide, and supporting early intervention among children and adolescents. So the teachers or school administrators, our guidance counselors are often among the first to identify early signs of emotional distress, behavioral challenges, substance use, or suicidal ideation in young people. So schools are therefore uniquely positioned to foster protective environments, to build resilience, and to connect students with the appropriate care and support services. So this consultation acknowledges that effective mental health policy cannot be developed by the Ministry of Health, Ministry of Mental Health, or the health sector by itself, but must be connected integrally with the educational sector. So Grenada's unique institutional arrangement, having both a Ministry of Health and a dedicated Ministry of Mental Health, Wellness, and Religious Affairs, provides a strong platform for partnership. However, policies and legislations can only be effective if they reflect the realities within the schools, including our classroom dynamics, the resource constraints, the teachers' preparedness, and the student support system. So your perspectives are essential to shaping approaches that promote mental health literacy, early identification, referral pathways, safe and supportive school environments, and the protection of the rights and well-being of our students. So strengthening the collaboration between the health and education sectors will be key to ensuring continuity of care and effective responses for children and adolescents in needs. So PAHO remains firmly committed to supporting Grenada in advancing mental health reform that reduces avoidable harm, strengthens suicide prevention, and equipped the education systems to respond effectively, compassionately, and in a manner that promotes lifelong well-being. So we look forward to continued collaboration as Grenada moves from consultation to action, and we continue to commend the Ministry of Education for its inclusive and forward-looking approach. So we thank you, and we look forward to the discussion ahead. Thank you very much, and I'll hand back over to our chair.
Thank you so much, Dr. Malcolm, and thank you for continuing to support Grenada's initiative as we build our mental health system. So we just want to remind everyone, PS would have spoken about the public consultation, so we'll advise you to help us to spread the word On the 3rd of June at 6:30 p.m. to 8:30 p.m., we'll be having public consultation at the Luke Cinema, Grenville. So please, we are advising that you invite every member of the public, the schools, the sports clubs, everyone, to come out and share their opinion, share their advice, share their suggestions as it relates to how we can strengthen mental health services within Grenada. On the 5th of June, same time, 6:30 p.m. to 8:30 p.m., we will be at the Agape Ministries, River Road. I believe that one is kind of central as you're driving to River Road. So we are inviting again each and every member of the public to come with your suggestions, your recommendations, your advice, as we have a public consultation within those parishes. And we are winding down our formal part of this of the day, and after that we will get into the presentations and discussions. So I now call to the podium to do his presentation our power consultant, Dr. Sumatra.
Thank you so much. My colleague Jasmine is going to do the presentation. I have to accompany PS to meet the minister for a few minutes now, so I'll be gone for a while, but we'll be back in about half an hour. Before I leave, I just wanted to lay out some broad ideas around the policy. The policy and the plan that we are doing is really a roadmap. Okay, it is not, nobody believes and and it has never happened that just because you wrote out a policy and a plan, things happened on the ground. It actually is a roadmap. So when you're developing a roadmap, it's always a challenge. As Taraleen Malcolm mentioned in her talk, that it needs to be realistic. It needs to take the resources that are available in the country before you make these roadmaps. But at the same time, it's also equally important to be very aspirational about wanting to do things, wanting to be more forward-looking and not to be weighed down by just the reality of what we live in. Because it's very easy to just be stuck in the reality and never be able to make progress. So it's always a challenge between trying to be realistically grounded while at the same time being aspirational enough so that we can make progress. And the second most important thing that happens with all of these roadmaps or policies and plans, especially in mental health, is for us to actually move away from the idea that mental health is the sole responsibility of the ministry looking after mental health. Mental health is everybody's business. And so actually a lot of the mental health interventions and improvements that need to happen have to happen from outside the health sector. So they have to happen in sectors such as education, employment, youth affairs, sports. That's where really a lot of the work is likely to happen. And so when we look at this policy, I think we should keep those broad ideas in mind. So I just wanted to lay out some broad parameters so that we don't get stuck into what can the Ministry of Mental Health and Religious Affairs do, but actually to say what can the government of Grenada do. And the government of Grenada is not just the Ministry of Mental Health, but it's the Ministry of Health, it's the Ministry of Education. It's all the sectors working together to be able to bring about improvement. So I would encourage you to look at the policy and the plan from that point of view, and to start identifying the actions that can be done by various sectors to improve mental health outcomes for people in Grenada, but especially mental health outcomes for young people in Grenada. Because I think that's your future. That's the future is the young people, and how can we actually make things better for them is something we should be looking at. So with that broad idea, I'm going to hand over to Jasmine, who's going to do the presentation. And as I said, I will accompany the PS to meet the minister and be back in 15-20 minutes, half an hour. Thank you so much.
Thank you, Dr. Sumatra. I think we all are substituting today. So I want to just say thanks for your patience, for indulging me as a substitute MC for this morning. And I will now turn over to the facilitator for this morning's session. So thanks again for your participation and for coming. We saw we had a newcomer, so we just want to welcome you to this morning's session. Jasmine?
But before this, it's important for us to just have a round of introductions. So for the sake of our consultant here, Ms. Jasmine Kala, the persons from the Ministry of Education who are here, we would just like you to introduce yourselves and state your specific portfolio. Thank you. Let's go clockwise. No.
Pleasant morning, everyone. My name is Earl Williams. I'm from the Drug Control Secretariat, Ministry of Education. I function as the Assistant Drug Avoidance Officer. Thank you.
Good morning, Elizabeth Japal. I head the Drug Control Unit, ably assisted by Mr. Earl Williams. I'm very happy to be here. I attended the session before this. I am really looking forward to this level of the consultation. And like I told Mr. Hector a few days ago, I think it was Friday, we had a sort of online meeting. I'm really, really looking forward to today and the contribution that the Drug Control Secretariat can make and the collaboration that will be established between Drug Control Secretariat, or strengthened, because it's not even about establishing, strengthened between Drug Control Secretariat and the Ministry of Mental Health. I am really happy to be here. Some of my colleagues are on their way.
Good morning, everyone. I'm Judy Ann Ald, Deputy Chief Education Officer at the Ministry of Education, but my specific responsibility is special and inclusive education. Thank you.
Good morning, everyone. My name is Pearson Strong. I'm the Director of Student Support Services at the Ministry of Education.
Dr. Niels Chaitin. I am a social and behavioral interventionist with the Ministry of Mental Health, Wellness and Religious Affairs.
You need to introduce yourself, Father Mark.
Good morning, all. My name is Edward Mark, Health Services Administrator, Richmond Hill Institutions. It includes the Richmond Hill Home for the Aged and the Monge Psychiatric Hospital. Thank you.
And my name is Josh Hector. the Director of Mental Health and Substance Use within the Ministry of Mental Health, Wellness, and Religious Affairs. So, Jasmine, I believe we can proceed. Almost is better than not at all.
we've got with the mental health policy and plan. The earlier bit of conversations that we had was it was drafted as a policy, and there was a bit of an action plan as well. So now we've kind of made a decision that maybe it just needs to say mental health policy as well as a plan. Oh, I see. Do you want me to just hold it? Thanks. Okay, so what I will do is just walk us through what is currently in the draft. But the idea mainly for today was to actually discuss what can we do together with the Department of Education. So I'd like us to highlight that bit a little bit more. But I'll walk you through the progress that we've made so far. As is understandable, we are, of course, as the government of Grenada, we're quite interested in looking at prioritizing mental health, and especially in the light of recent events. There is a concerted push to say that we do need to reform our older mental health legislation as well as rework our mental health policy. We do know across the world as well, there is a lot of stigma and discrimination that people with mental health conditions face, which can reduce your access to care and services. And that is why the government of Grenada has committed to developing a national strategy for mental health as well as suicide prevention. And currently, we'll focus more on the mental health policy and plan. Of course, it has been developed in consultation with various departments, various ministries, as part of the Ministry for Mental Health. The very broad purpose of the policy is to say, how do we improve access to quality of mental health care? How do we promote mental health and well-being with a focus on a rights-based approach? And what does that mean is something we'll uncover. The scope of the program, as you can imagine, is to cover the entire spectrum of activities and work that needs to be done in Grenada. Part of it makes a nod to addiction, substance use, as well as suicide prevention. So we can keep some part of the discussion around that as well. The broad vision for the policy and plan as of now is to say that how do we make Grenada a country where mental health is valued, it's promoted, it's protected, where people with mental health conditions are able to exercise their full range of rights to be an equal member of society. So this is looking at primarily high quality, holistic, community-based care. So it's not just looking at clinical services, but more life course approach, more preventive. Where can all of us kind of play a role in looking at mental health? Part of the policy statement is emerging from the national strategic plan that has already been put in place, which is committed to improving mental health of all people. It is placing healthy population as an asset for us in Grenada. So essentially, just to, I think, highlight a few words, is looking at promotion, protection across the life course, which is where I think the Department of Education becomes even more crucial. We're looking at promoting and providing community-based, integrated and rights-based care, to I think your point early in the morning. And how do we engage people who already have lived experience to become a part of this solution rather than providing things to them? How do we do this jointly? And foster advocacy through nonprofits, kind of leverage the space that we already have in Grenada. So based on all the conversations that we've had so far, there are 5 strategic priority areas that are emerging. And this is also based on the guidelines described by the World Health Organization on how the policy should be drafted. So the first one is looking primarily at governance leadership for mental health. The second one is looking at more fostering comprehensive, integrated, community-based care. The third one is where I think a lot more interesting conversations can happen, is looking at intersectoral collaboration for promotion, prevention of mental disorders and rehabilitation, where we are recognizing that mental health cannot and simply sit within the Ministry of Mental Health. So how do we collaborate together to make sure that this is a holistic response and a community-centered response? There's been some more focus on looking at information and research. So how do we improve our data set to respond better to mental health? And the last bit is then elaborating on the rights of persons with mental health conditions. So the next part of the presentation just kind of elaborates on each of these 5 areas. So let me walk you through the presentation and then we can park some time for discussion and some opening up specifically more for Department of Education and the Ministry of Mental Health. So I'll keep going. For the governance and leadership, okay, sorry, this one is jumping. No, all right. So the idea is that the mention was made in the morning address is that there's also a mental health legislation that is being worked upon, and I think Josh later at the end is also going to walk you through what has been put down as the drafting instructions for the mental health legislation. There's obviously a huge push to say decriminalizing suicide is again part of a huge priority for Grenada. So as a signatory to the CRPD, which is the Convention on the Rights of Persons with Disability, there are certain rules and regulations that we need to change in the domestic space to make us aligned with the CRPD. Now, the Convention on the Rights of Persons with Disability is essentially saying that people have the right to live on an equal basis with other people, irrespective of their mental health condition. So based on all of those guidelines and the international standards that have been put in place for what our mental health policy plan should look like, the following suggestions have been made to reform the legislation as well as decriminalize suicide. So that is something that is being worked on. I'll probably not mention too much because we have a whole section walking you through what is being proposed. The idea is that how do we focus on implementing a rights-based legislation, establishing required authorities, training professionals, and building public awareness. So you'll see that there are lots of action points within this domain as well. Some of the expected outcomes that we've put down for now is that authorities required under the new laws have been established, awareness and education sessions have been conducted so that people know what is happening and what is being planned. The next bit is increasing funding, which is again based on international conventions and general good practice is saying that a minimum of 10% of the overall health budget should be retained for mental health services. But more importantly, it's also decentralized care to primary health services and communities. So not standalone institutions, but actually to decentralize and provide community-based care. So the expected outcomes, as you can imagine, are looking at whether the 10% has been allocated and whether it's been reorganized towards the strategic areas. Now, something that we've also been quite careful about is, and what we've heard is increasing participation of persons with lived experience is quite a given. And I think through the consultations we've had, everyone has spoken not just about people with lived experience, but also their families and carers. And this one is saying that people should be engaged not just in policy making, but also monitoring and evaluation of services. So there is an added sort of responsibility, where the expected outcome is that can we look at supporting and establishing national and regional association of mental health service users. And here the conversation that the feedback that we received is also for carers and families and not just people with lived experience. And the idea is that can people be engaged in mental health policies, services, and care, and like it's already written about evaluation as well. So I'll move to the next strategic area, which is looking at comprehensive, integrated, community-based mental health care in collaboration with other sectors. Part of the big strategy and the plan has been how do we move away from standalone mental health hospitals, in our case, Monge, and make sure that services are available at people's doorstep. They're of good quality, they're accessible, they're affordable, and being part of it, but basically at people's doorstep. So the whole strategy, if you will see, is leaning towards more like, I think, years and years of advice and direction to say that we should not rely on just standalone um, psychiatric facilities, but move away from and move them into the community-based services, which then again takes a whole life approach and a whole community approach, which then looks at prevention, promotion, as well as treatment, all happening at the community level. So the idea is that the services will now need to be reorganized from one standalone hospital to looking at a slightly more community-based approach, which also has evidence of reducing human rights violation, which typically happen if you only have one hospital or a series of hospitals. Here, I think the attention I want you to pay is just looking at how do we establish community-based facilities to resettle people who've been at the long stay hospital, which is currently the Monge Hospital, because we understand that there's some people who've been there for many, many decades. So what is the pathway to moving them back into their communities? So reintegration, deinstitutionalization is the future that we are looking for in Grenada. Which will also mean that community support teams will need to be set up. And I can then move to the next part, is also then looking at, if you're looking at decentralization, apart from Monge, where should these services be seated? So it's about developing, strengthening acute psychiatric services at the general hospitals as well. Again, I think this was already the part of the strategy. St. George's used to have an acute psychiatric facility. For various reasons, that's being redone. But I think we're closer towards reintegrating back to St. George's Hospital rather than just looking at Monge. We know from experience that if we do this, that it'll reduce the patient in numbers, which are kind of in line only at one service, and actually open up all the other services that could be tapped into. The expected outcome here we were looking at is that the acute mental health ward has been moved back to St. George's. Inpatient and outpatient, both of these services, so not just outpatient care, but as well as inpatient care, can be integrated at the public hospitals, which can be, which are services like at Princess Alice and Princess Royal. And the other bit is that looking at outpatient care needs to be improved and increased, which is available across all of our 6 districts, including Carriacou. Again, within the theme of deinstitutionalization and community-based care, the idea is also how do you integrate mental health into primary care as well. So that was acute services, and this is primary services, which will require that people will need to get trained on what to do when there is a person with a mental health condition coming at the primary level facilities. So again, early identification, early detection, early treatment that can start so that people are not suffering at the end. So training of the staff needs to be done, and there are these WHO MHCAP modules that have already been designed, which are primarily looking at integration of mental health and physical health. The expected outcome, because we anticipate that this is entire 6 districts, is looking at maybe a national training coordinator who will be appointed at the Ministry of Mental Health. People have received the training, they know what to do, they're being monitored, and they're being supervised on how to actually change their services. So there is a provision for refresher training, supervision, and the anticipation that more people will start seeking services at the primary care rather than looking at tertiary care. Because suicide prevention is an issue that is important to us in Grenada, there is a section of building capacity for suicide prevention services, which will include things like training again, but it's also monitoring and supervision. So after training, how do you change your practice? How do you get supported enough to make sure that practices are actually changing? Again, there are some evidence-based modules that already exist, so how do we incorporate that at different levels of primary care staff? In the expected outcomes, it's primarily looking at training and people being able to identify people and provide care. I'll move to the next strategic priority, which it's a bit slow, sorry. So this one I think is where the interesting conversations need to happen, and more relevant for today's discussion is looking at the intersectoral collaboration, because the scale of the problem is huge and there are many pathways that we can do to actually fix our mental health condition problem, our suicide problem. So part of this section is heavily focused on collaboration, preventive, early prevention, early detection, but as well as just creating an atmosphere where people know what is happening, especially the youth, especially children and adolescents. So what can we do together? This section has some description of different departments that we have engaged with and their recommendations that have come in so far. But again, this is more open to conversation. Yeah, sorry, the slides move for me, but not here. Okay, it's just taking a while. One of the things we've heard again over and over is there has been some precedence and history of setting up a MHPSS, which is more mental health, psychosocial rehabilitation kind of an approach. Unfortunately, it's become very disaster focused, even though actually it should exist without a disaster as well. Now, in the history of the hurricane, this technical working group had been set up with various ministries, where we heard that was quite like a positive thing, where everyone knew what they were collaborating on and how they could work with each other. So one of the recommendations that came quite strongly was to say, how do we keep this as a technical working group, which is a standing working group, without having to wait, say, for a disaster-like situation? How do we take this on a more sustainable long-term goal, where it can be housed within the Ministry of Mental Health, but actually get the involvement from different ministries. So some of the ministries that we've heard were part of it was health, social development, education, youth and sports, legal affairs, labor. So this is what we had heard existed, and the suggestion is to then, we've been hearing from everyone that this should become a standing group. As you can see, the purpose of the working group is how do you coordinate, how do you not overlap, basically how do you maximize and leverage the potential of each of these departments to do something about mental health. Some of the expected outcomes, which is more plan focused, is looking at terms of reference, regular meetings that are being held. The next one is looking more at Ministry of Social Development, where there was, because housing, homelessness, gender, a lot of the psychosocial support are sitting in social development. So there's obviously a huge amount of leverage that we can do with collaboration, and which is why you will see that the idea of doing more comprehensive services with mental health and social care came up as a huge need. Especially for looking at people who are homeless, especially for reintegration from, say, long stay facility at Monge, how do we reintegrate them back to communities? So which is why you'll see some bit is looking at community basis residential homes, which is again a common practice globally, where people who actually need to get out of the mental health facilities is to actually get social care more than actually even medical care. So what kind of provisions can we do together collaboratively, because anyway social development is already doing it. So again, a focus on psychosocial programs, number of people who are receiving social benefits, including disability benefits, and for people with more specifically more homeless population. Now, this is the conversation as far as we had gotten last time, which was looking at, with the education department, the ministry, is to look at what can we do for children and adolescents. And what we got to know is that there is already a mental health, there's a life skills program that covers a lot about the mental health interventions as well. So how can we then collaboratively work to do more promotion, prevention for children and adolescents within the school space as well? Now, this is where the conversation, we got some feedback to say, let's talk more, because life skills is one part of it, but there are multiple other programs that are happening at the Ministry of Education. So how do we find these pathways to collaborate? So part of the reason for today's meeting is to expand on this a little bit further, for us to be clear what our potential plans could be and what our potential outcomes could be. As of now, because it's focused on mental health life skills, there was a focus on adequate number of trainers, our teachers being trained, our children and adolescents being trained, and are they being supported to actually deliver this training? So this is how far we got with the conversation, but we wanted to reopen this piece more specifically today. Then there is I'll probably not get into too many details, but one of the comments that came from the consultation is, should we do a nationwide campaign? Should we do more myth busting? So there is some space of looking at information sharing, myth busting, encouraging people to seek help. So that part of the campaign kind of exists there, which is again primarily sitting with the Ministry of Mental Health. Then there was a focus of looking at Ministry of Sports and Youth Affairs. So this is how far we got. It's mainly sports, to be honest. So Youth Affairs, we have a meeting with them, in fact, today itself, to open that conversation again. But this for sports is to actually make the link between mental health and physical health. So what can the Ministry of Sports be doing? There are lots of coaches who can be trained as people who can provide psychological first aid. Psychological first aid, very simply, is we all have physical first aid, but we don't have psychological first aid. So some basic amount of training, using coaches as one of the mediums, making sure that athletes and coaches have access to training. There was a specific focus for them saying performance management was a huge issue within the Ministry of Sports. So we've put that down. And of course, monitoring and evaluating whether this is still working. The next bit is slightly more straightforward. This is looking at mental health information systems and research, where we know that we don't have enough data which is coming in. There are good systems in place in Grenada for physical health indicators, but they're not being integrated for mental health. So there have been a series of conversations where they're changing the health system collection system to make sure indicators are being measured, people are entering the data, so that we can understand what's happening across the 6 districts. So this is, as far as I know, moving quite well ahead in terms of collaborating with the technical systems that exist. Anything else? Yeah, so the other bit is looking at a surveillance system, which is again another evidence-based way of understanding what is happening in Grenada, what is leading to probably what age group, what conditions are then leading to, say, death by suicide. So this is again a surveillance system that we can put in place for Grenada to understand our data better. And the last bit of that strategic focus is looking on protecting the rights of people who already have mental health conditions. Anything? Well, this one is essentially saying that people who do have mental health conditions are kind of automatically ostracized from society. They're not being included, even for the basic amount of decisions that they need to make. So the focus is, how do we uphold freedoms and rights of people with mental health conditions so that they can participate on an equal basis with others. Some of the strategies that have been listed down is looking at programs developed by now Standard World Health Organization, tried it out, tested, scale it. So part of it is training, part of it is looking at indicators of reduction, for example, in involuntary admissions. Something that has come up more specifically in Grenada was the issue of abandonment of people with mental health conditions. So how do we address the abandonment bit is, do we need a specific strategy? How do we work with families? So a lot of the comments during our earlier consultations was, how do we work with carers and families, and what social protection could we give them to make sure that they're not being abandoned and can be included within their homes? Again, so the expected outcome there is looking at reduction of abandonment. Part of this is more around the execution of it. So compliance is who will oversee the policy, and implementation is, of course, the Ministry of Mental Health, but making sure that they collaborate with different ministries, so the technical working group becomes an integral part of it. The monitoring and evaluation, again, the reports need to be sent out, so making sure that we've put in the provisions in place so that this does not lose traction. And the review that should be happening is typically you kind of make a plan for, say, up to 3 years, and then we need to revisit it to make sure that Grenada still requires these actions, or should we change them. So that's it for the policy bit that we've read so far. Any questions, comments, concerns on the broad overall policy, and then we can move into the narrowing down of the Ministry of Education bits. And I can see Josh is not here, so. Okay, good. So let me, any comments, any thoughts and reflections? Is this feeling like it's going in the right direction? Any major flaws that you can already see, or gaps that we should be addressing? Should I just pass the mic to you?
Thank you very much. As you presented, I was reflecting on my days of teaching. And one of my reflections is that of young children who would be suffering from mental health issues, and the parents may not look at other channels to get that child support, however, may just turn to religious rituals. So, and this may or may not cause further harm. Okay, because I have seen some things like that in some of the communities. How can the policy give support to a child who are faced with a situation like that, when they have to obey their parents to do what the parents ask them to do? Yes, and to become part of that religious ritual who that child has no control over because of the situation, the mental situation. While I was coming down this morning, I felt sort of a bad, because in my community I was seeing the police arresting, should I say arrest? The police were going with a young man who has issues with mental health. And he was basically in the middle of the streets, you know, making gestures to block the streets and so on. How can we help these people? Is it just go to the mental institution, return to the community, and there isn't any greater family support and so forth? Yes, I noticed that the policy is speaking about those, but greater involvement needs with the community. Yes, so I was just reflecting on those this morning. Thank you.
just to repeat, this is loud. The idea was to also examine what is already being done to support children who might have a mental health condition, maybe not formally diagnosed. So what are you currently doing? What are the programs? What are the training that already exists? And how do we collaborate on that a little bit more?
All right, so good morning. So the Ministry of Education, through the Student Support Services unit, has a cadre of counselors within our school system. I think I want to, first of all, say we do not necessarily have all that we need. So there are schools. So the structure is that we should have at least one counselor within the secondary school, resident, and we have a cadre of counselors who visit the primary schools. So we have on average, one counselor will have 7 to 9 primary schools that they are responsible for. By that, you would understand the inadequacy already in terms of being able to really provide the service as needed. However, it's better than nothing. So I don't want to give the impression that nothing is happening. A lot of work is happening, and we are preventing things that could have happened if they were not there. So I want to make sure I establish that from the onset. And we have a good cadre of trained therapists who are working. Most, if not all, of our persons, we may have just taken in recently some persons at the first degree, but they are all now getting their masters. So everybody who is functioning at the level as a counselor is a master's degree or person being trained at the master's level of counseling, therapy, or psychology, one of those areas. So the staff is trained. What we do have is an inadequacy in terms of number. Best practice tells us that we should have at least one counselor for every 250 students. That does not happen. This does not happen within our system. That is the counseling part. I think Dr. Alt maybe can speak to a little bit about special ed, which is also a part of our interventions in terms of our system. So that's pretty much what we have on the ground in the school system at present. I know, and I think maybe what you are referring to in terms of the life skills, you may have spoken to the curriculum officer who may have spoken to family life and so, which I think does speak to some of that, which is where I think you may have gotten information from in terms of being taught life skills. The issue with that is that while it is a good program and the curriculum does have a lot, unfortunately within our system, if schools have the option to drop a subject, is going to be that one. It tends to be the one to get knocked off. It tends to be the one to left not necessarily done. We don't necessarily have a teacher all the time in every single school assigned to that particular role, and of course it's not a examinable subject again as well. Very often is not going to be the one that's going to be pushed off often, and so I think maybe that's who you may have spoken to in terms of that. So that is where we are. We have some counselors in the school system. The issue with us is that we do not have the numbers that we need to be able to really seriously, in terms of best practice, to seriously address the issues that we have. Some testing is done, some assessment is done. We have persons at different levels. We cooperate as much as we can with Dr. Francia and Father Mark, wherever we need help, wherever we make those requests whenever that is available. To us, we try our best to see how we can collaborate with the other areas in terms of mental health provision within the system.
And last time, I think we were discussing how you're collaborating with the social development for the counselor bit, or has that?
Well, we again, the ministry, all of the ministries, because of our reality on the ground, we have to share. So whenever there are instances, so for example, if we have an issue within the country or so, some of these things may become public. fires, whatever the case might be. They will handle the parents while we handle the children, because the children are in the school system. It is not written down anywhere, but that's how we practice. We work with each other. We are very familiar with each other, and I guess the issue here with is that because there's nothing written, if something happens, then you don't have a documentation that says that the person coming on, let's say somebody leaves a post, you don't have that necessarily, you don't necessarily have the idea or the understanding that this is what happens. Somebody will have to be retaught that. So maybe what needs to be done is to formalize out to MOUs and those kind of things like that, to formalize some of the arrangements that we have. But yes, of course, we work collaboratively and consistently with the persons within the other ministries where there are people who do similar work to us. So we share that.
Good morning, everyone. I'm not sure if it's a comment or a question, but in terms of the surveillance, given that Grenada has a surveillance system under the Ministry of Health, would our mental health data be accessed through that, or would there be a completely different surveillance system set up for mental health?
I think there's been some update there.
Thanks for that question, Matron. So the good news is that we've engaged the EPI unit, and through the District Health Information System, that's the DHIS2, we're actually on the verge of, excuse me, we're on the verge of beginning to understand how to populate a mental health module. So all the indicators, for example, just based on international best practices, we'd have to pull up all the indicators to make sure that we're covering the bases. And once we get through with this, and of course I'm answering this question now, even though I would have gotten to share that with you very soon. Once this rolls out, then we will also be able to have mental health data in the weekly bulletin that goes out. So surveillance would be a very real thing. We're on the verge of having an active mental health surveillance program in Grenada.
Okay, thank you. So one of the things that jumped out at me is basically having quality care available at the patient's doorstep instead of having them going into the hospital or institutions. And it's all because of the stigma, to destigmatize. Because from my end, at special education, most of our students, especially those on the spectrum, they display a lot of behavioral challenges. They're injuring themselves and they're injuring others. Those that are on medication tend to be able to manage, but parents do not take them to the clinics because of the stigma. And even if they go and they're medicated, again, because of all of the myths around the medicines, the parents do not administer to the children, especially the teenagers. So we have some teenagers now in our secondary schools that are really injuring themselves to the point where it's becoming scary. So I'm hoping that once we're able to destigmatize the convenient way for the parents and the students, we may see better results.
So just as a follow-up, so I think this is something we've heard over and over, is the involvement of families and parents as part of the treatment and care as well. So do you think that this bit needs to be highlighted a little bit more? And are there any touch points that the education department has with the parents where this could be sort of integrated, that, you know, you become the channels of communication rather than, you know, coming from the health sector, if you know what I mean? Because sometimes that's less stigmatizing. If you were to say they anyway trust you and they would believe you more.
Yes, we do, because like last weekend we had an incident where I was called in the night about 9 o'clock where one child would have, she broke a window and used the pane of glass to damage herself. And the mother, I encourage mom to take her to the health centers, not even to the health centers, to get it properly dressed, because in that case, the family doesn't want it to be out there in the open. So mom was taking care of the wound herself. And so while we do have that relationship and the parents are able to open up to us, they're just not comfortable going forward. Assistance.
And so you're saying that it's not comfortable for you to intervene in these aspects because you're ill-equipped. You don't know what to do in these
we can
situations.
support mom as best we can. We can counsel mom, or we can encourage, but that's so much we can do.
True. So there is trust. People are reaching out to you as teachers, as educators, and then how do we work together to build enough skills is what I'm hearing. Okay, perfect. Yes.
It's just a suggestion, but can we allow teachers to make written referrals, like based on the symptoms that the child may possess?
Yes, we do. That's what happened. We have a referral process.
Do you make referral to the clinics for them children?
Yes. So once it's outside of education realm, we do refer to the health system.
And is that something that's written or, sorry, Father Mark, I think you want to comment.
I just wanted to, the difficulties that education is facing as it relates to parents really coming forward and cooperating. Some years ago, we had what we used to call the child psychiatric clinic, right? Stigma. So that is no more. We say it's called the child wellness clinic. It is not at the psychiatric hospital, it's at the general hospital. And I believe we are at the junction whereby, well, collaboratively, we have to work with our parents and guardians, because when it's beyond the school, yes, when it's beyond the counselor, a referral has to be made. And once you sit with the parent and have that discussion, you explain, me, I don't want my child in that. Me, I'm not comfortable with that. Of course, a lot of counseling goes more to the parents. Some, after a long conversation, I say a very long conversation, and say, okay. And about 2-3 weeks after, they would call and say, well, I'm ready. Could you make the appointment? Others, you keep in contact. I'm not in that. Now, my colleague raised the issue of this rituals, right? And that is something that if we don't have early intervention, it could affect our children. So, for example, a lady came and said to me, listen, my child have a demon. As a counselor, I say, go straight to casualty. Go straight to casualty. Let all the medical efforts be exhausted. And I said, if that is the case, it is totally exhausted, then I can refer you to an exorcist if your child has a demon. But I do not just say, well, okay, let's pray. Go to casualty. There must be, yes, these medical exams, of course, and if it warrants seeing the child wellness consultant, of course, that is done. So the challenge there, more so, we have to find other techniques whereby we can really reach to parents, or if it can be enshrined in the policy where it mandates, based on the referral of the teachers, principals, counselors, and so on. All right? The child's behavior reaction to, so once it crosses that line, then based on the policy, he or she must be seen at the child wellness clinic or perhaps another level of counseling.
Yes, I wanted to commend you on your wonderful presentation. I know it's just a synopsis of the policy, and we will have to, go through it to get to all the nuances and so. But when you spoke about training, I was happy to see the aspect of training. And like I said, I know you didn't delve into everything. But I hope in the training, we're not only going to be training staff and people at the level of advocacy and so, but we also need to train gatekeepers, the driver of the vehicle, the police officer who's, like Mr. Williams mentioned, who's detaining or arresting or whatever is happening there. I have seen it with my own eyes, where at the Mongay facility, I happened to be visiting one day, and someone was being admitted, a client was being admitted. And I saw security wrestling, and it was very tearful for me to see the client on the ground and they're wrestling. And, you know, I think the training has to be for security, policemen, everybody, not just nurses and doctors and us in education, etc. And again, the parents and everybody in the community. So if we train or young people are exposed at the preschool level to understand that mental health, ailment or disorders are part of regular ailment and disorders, then our generation would grow up knowing that if somebody is mentally ill, it's not because, like we say in Grenada, they're crazy, but our students will learn to look out for that for their peers. So I think we have to make a concerted effort, and I'm glad this is education officials here, that we need to start the awareness education with the preschoolers, build on it, and again, ensure that parents, through the PTA, through community dialogues, and so are trained and to understand these nuances as versus maybe a tunnel vision as the child is possessed or so in that regard.
Well, without jumping full on into the legislation, the training, the required training for those who are serving, that will be legislated as well, to ensure that the people who are meeting the needs of persons who require those services understand how to protect human rights, how to uphold dignity, and they're also trained to understand how easy it is to do the opposite.
Yes, I have a mic. And I'm speaking in a general sense. Thanks, Father Mark, for saying that. And I think I just want to reiterate, or should I say, put my vote in that I agree with him, in the sense that unless we make some of those things mandatory, we're not going to have the issues. And he's very cognizant of the fact that that is where we normally have the issue. The issue doesn't come with us not referring. We know when we've reached to the place where this has become no longer, this has become psychiatric. We know that. That's how we practice. We know our people are at a level where they understand this needs a psychiatric view as opposed to psychosomatic or neurosis. We know we work with neurosis. We know they work with the psychosis, and we understand that. The issue comes when a few things happen. We make the referrals. Sometimes they go to the first session. But that report that's given, we don't get that report. That report goes to the parent because we are not the parent. And so we don't even in some cases have access to the report that's given. So we don't get the opportunities to, and so there's nothing there that says that we need to see that. It's up to the parent. And so if the parent does not share it with us, we don't know what the psychiatric view is as to how we might be able to put a plan together, or a recommended plan as to how we work with this child. How do we allow or support this child within the system? These are some of the issues that we are dealing with that I believe we have to pay serious attention to if we are talking about a policy. We also have to get to the place where we understand or we accept the fact that if we're going to speak to parents, it can't be a one-prong method. I think that all of the areas that we've spoken to, whether it's through PTAs from us, whether it's through the national, the mental health from a national, in other words, we have to necessarily bombard them with the information from all sectors and from all areas so that that message is being sent. That this is mental illness is like any other illness, and we have to keep sending that message over and over again. And then the last point that I was going to make in terms of the training, while I know and I fully agree, under no circumstances am I disagreeing with my colleagues in terms of the need to train and who we are training and making sure. We need to also accept that we also have an issue where we need to help our people to know how to protect themselves. Because let's not pretend, in some cases, if these persons are psychotic, they're not necessarily going to be able to maintain themselves. It's not just about knowing how to deal with them. It's also knowing how to protect themselves and using particular methodologies that would then not just speak to honoring the rights of the person, but also protecting themselves. These same people who have to honor their rights also have a child home. That if you hurt them and they become disabled or whatever case, their children are left without a father. So it's just as simple as, oh yes, we train, but with all of the aspects that we have to do a 360-degree look at this. That is not just about honoring some client's right, but it's also making sure that in my training that I'm also know how to protect myself, how to make sure that I know when it's time to quit, when it's time to and those things like that. So I'm hoping that we're talking about that type of training and not just about honoring a client's or a patient's right, but it's also the carer themselves knowing and understanding how to protect themselves. Because that carer has a family, that carer has children, that carer has a spouse, that carer has other responsibilities. So let's make sure that we do our 360 look at this and make sure that when we're talking about training, we don't just look at one aspect of it. Yeah, thanks.
Just want to quickly let you know, Mr. Stroud, that the rights of service providers is also included. It's not just the rights of the patients, but the rights of the service providers is also being taken very seriously as well.
Rights is okay. I'm still on it. Rights is okay. I have a right too. But then where are the protection for me as a carer that speaks to me, that says to me, all right, at this point, I need to. So if those rights then speak to that, okay, good. So thank Doctor for answering that. But if those rights only speak to what I have a right to use, but I must also speak to where are my protection.
So
where is the place that I need to stop or I need to check when it is going to be too much for me, or I understand that they're reaching the limits where I could possibly get hurt and understand. So if the rights speak to that, then okay.
So when we flesh that out in the legislation, you're going to have a comprehensive look at that.
But also, I think what I'm hearing you say is that there is one part is just making referrals, but how do you make the referrals? When do you make the referrals so that you are also protected and the person is protected? Because protecting one group's of rights will mean protecting every group's of rights. So if that is the client and you are the service provider, without your rights being protected, anyway you can't protect anyone else's. So that is part of the ecosystem. So the rights framework will allow for those conversations. But I'm hearing you say like the training then needs to be practical, implementable. Where are the standard operating protocols so that I know when to refer, whom to refer. But the more interesting part is how does the data feed back to the person making the referral? So if we are making a referral, I think that's the bit that we should probably try and unpack.
Yes. In a lot of cases, we can't make the referral. It's a referral. Yes, a referral is made, but a referral is more. We might basically say we need this child has to see thing. But in most cases, what is requested is that a parent is the one who has to really make the official referral. We do not necessarily have jurisdiction over the child in that sense. It's the parent, it's the main carer. And so that is where it comes where, one, we have to be allowed to be the ones to make the referral so that whatever report that comes back, it comes to us as well. And even if it's the parent who is making the referral, that there's something that says that whoever the agency or so that the child has to be existing in on a daily basis should at least also have some kind of a feedback in a real way to be able to know how to relate to how we work with the child.
I think I want to go a little away from that part. Oh, you didn't see? Kathy and James, my apologies. I had a meeting with PS. Kathy and James, Deputy Chief Education Officer with responsibility for school administration. Right. So, in my thoughts, and I'm listening, how do we integrate mental health in the life skills part of education? One of the struggles we have within education is that we constantly talk about things in silos. Meaning that if we're thinking about life skills, we want to say we want to have a life skills class rather than how do we integrate life skills in all of the curriculum, all subject matter, and not just have it as a separate. And that would be a challenge in any system. How do we integrate and not have it as a, so you have your soft skills, 45 minutes for that. But how can we put it into English, math, social studies, geog, all of those things, even chemistry when we mix in the chemicals, all right? Because they can use the same chemicals to do things that are harmful to others. How do we? So let's think about the how in this. I'm also thinking that we need to change mindset. And changing of mindset means that we know the stigma that is attached to persons with mental health. And sometimes I say if we're not in it, we will never understand what these persons are going through. Or if we do not have a family member who are affected, we may not know what to say. But how do we? What do we use our media for? And is there a part in the policy that really speaks to sensitization that would take a whole approach rather than just not a mental health week, but the entire year you're learning about this, how this is happening. Where does theater comes in? I'm a theater person, so I'll go put it in. Where does that come in? How do we use theater to help our citizenry understand mental health? How to deal with it. And that would come in with this training and the simulations and all of the things. Because once you have these theater backgrounds, you can have the discussion after, which will kind of open the eyes to persons and get them to understand and realize some of the difficulties or the challenges that are happening there. So our sensitization, we have to be very on top with this and not just have, I don't want to hear about a week or a month. I want to be able throughout the year to access knowledge and information as it relates to mental health. All right? How do we utilize our television stations, our radio stations, programs to bring across the message? Social media, what do we do? All right? Even use our same students within to share the message. How do we use persons who they have their good days and they have their bad days. But when on their good days, they can share. So these are the things that can help us for persons to understand really and really look at really integrating all of these life skills throughout our education process.
I mean, the first part of what you said is the dream, right? If you could integrate a lot of the life skills learnings and applicability across all subjects, is I think you're in the right position to champion that with education for sure. But the other bit, you're absolutely right. There is a whole provision for a national campaign. I think Josh and you should have a chat about how to make that clearly more impactful, which is more exactly that's the point. How do you make it year long? It's not just one event, but have resources available.
What came up in our last consultation, the very last one, was the idea of having relayed information. So instead of just having everyone jumping on the mental health month, for example, information is relayed across different sectors, and it's not happening sporadically because we have collectively decided in this month education is going to do this, which is going to lead to what mental health is going to do next month, and then social development and so on. And of course that can that can actually come to a head where we collectively share the same thing at the end of the year. Right? So that was a thought that came up, and I thought it was very powerful.
Can I just comment on Ms. James? Your concern there. I work along with the NULO, so I consult for NULO. And recently NULO, of course, restructured the program. So one of the concern was, and I'm using it as an example to answer your question, because in NULO you have what's called the ADP, right? The first 3 months of any training happens in life skills, soft skills, and that happens in St. Andrews. And then afterwards they go to Palmis for the actual training. So what we suggested as we reworked NULO was that the instructors of NULO, plumbing, mechanics, whatever it is, become aware or study the ADP program, the curriculum. So they're not teaching it, but they're supporting it. So the first 3 months is where the ADP goes hard. We go hard at it, right? Teach them honesty, all kinds of stuff, right? Work ethics, time management, and all that kind of stuff. But then when they go into the training, the skill training, the teacher now in plumbing, for example, or electric installation says, okay, when you go in somebody's house to wire, you got to be honest because you're going to see stuff there, and if you take it, then you know, then that you just stole. And then you could, so at every level, in every class, we ask the teachers, the instructors to highlight these virtues or this soft skill, this life skill things. So they may not teach it in electrical like the whole course, but they keep highlighting it. So I would suggest as you said, in chemistry, you could mix some hydrogen and blow up a whole place, right? But if you could teach that young person the importance of being responsible, being respectful, and the teacher does that while he's teaching chemistry, I think that will go a far way.
So I suppose narrowing back on the policy, there is a section on the life skills program. Do we need to edit that? I know that you missed the presentation and I have lost that connection link again. But essentially there was the focus of looking at collaborating or strengthening the life skills program operational. Do you think
No. I think what I think happened, I think you may have interviewed Ms. Bartholomew. I believe it's Ms. Bartholomew. So who is responsible for Health and Family Life, HFLE? That is already on the timetable, so to speak. The issue comes where, as I said, sometimes it's the easiest one to drop off in terms of a day, how things run, when they have sports and match pass. Those are the subjects that tend to get knocked off very easily. So that's really where the issue is. So it's not really contradictory to what DCO James is saying. For that one, that is already on the timetable per se. The issue is us, from our side, is to keep pushing for our teachers to value that time as much as they value math and science, those kind of things like that. But yeah, but I don't think you should be taking it off. And I think maybe what you might need to do is put a / HFLE. As well, just do a / with HFLE. I think that's where the life skills are being taught within the HFLE curriculum. And think that's pretty much. I don't think you should take it out. I'm just thinking that it just needs to be add on the HFLE. Yeah, that's just add on the HFLE. Just put a / with it, and so that persons reading it will understand where you're coming from. Yeah, I think that's really good.
While we're talking, I think the teacher ed department that's where Ministry of Education can also advocate because we have teacher training. So the teacher ed department within TAMCC should have some sort of discussion, some sort of sharing on this issue so they can encourage the integration, as Dr. Chaitan spoke of, into their teaching. All right, because we're talking about morality, we're talking about a lot of things there, values and virtues and so. So if they can get how they can fit this into, it can be an elective, it can be something that will cause them to see the value while they do the delivery.
Just wanted to address one more thing, and it may not speak towards the policy, but I'm hearing the concern from education, and that has to do with stigma. You know, the way we characterize students. Yes, it could be demoralizing. Some parents might have a problem with it, but I also believe it has to do with your approach towards it. For example, right now, currently, folks that you know in education, you know that I work as an interventionist in your high schools, right? Most of the principals call when there are the issues that, you know, tough issues. Currently, as we speak, at the Deluxe Cinema in Grenville, we have about 90 young people coming in every Tuesday. It's going to be happening tomorrow, right? How did we get SAS, for example, and GSS, that's Grenville Secondary, to send their students? Because we did not say they're behavioral children in the letter we sent in. The letter I wrote to the parents and the principal signed, it did not say behavioral children. My letter simply said that we are identifying a group of students who we believe have the capacity to be very successful, but they need polishing on the edges, right? You know? And so parents saw that this was a help for the students. We didn't profile them and say that bad boys that are, going to be suspended or that kind of way. We simply said, look, these children, we believe that these children have the potential to graduate at Form 5 level and do very well. But of course, they may be facing some challenges, and so we are here to help you. Guess what? Every Tuesday, the cinema is loaded. These children come on their own, you know? So I think it's the way we word it, because if we say anything negative, because parents always think, well, the school is not just about to get rid of my child and label my child, and they can't handle themselves, so I'm going to get rid of them. But if we look at it in a positive light, I think we could get it. I'm getting it right now.
Essentially frame the language with the children and adolescents as well to do that. Just a clarification question. Now, this is an interesting point. So you're saying that the training education department, the training ed is training. Teacher ed department, is that for in-service training, or is it the teacher training before service, before they come into it? Do you think there's an opportunity at pre and in? In-service. So the suggestion would be to then look at in-service training and there are different levels, I suppose, for different years of experience that they might have. Got it. So that might be another place where we can look at the curriculum, see what the mental health department could do to look at improving some part of that curriculum. Okay. So far, I'm just trying to, sorry, go on.
Oh, no, I was just saying, because we're moving into the digital harmonized curriculum, it would be a very good thing now to embed it into that DOHPC. So as part of a lesson. Or digital curriculum, because we're moving into a digital curriculum, it would be good to embed it into the lesson planning for our teachers.
No, I was saying that some of the concepts that we have can be sold through the school's PTA, because most, if not all, I think, all of the schools have their PTAs. Yes, and they have various meetings from time to time, and a lot of those could be sold to the PTA. Again, we also have to look at other students. Because these could also lead to students bullying others and so on. So we have to look at all the different components. Yes.
That's quite interesting. Are there any programs which are looking, say, students supporting other students? Is there already a channel where maybe you have ambassadors, people, current students who are probably involved in that?
Yes, we are. Is UNICEF? UNICEF? Is UNICEF? It was OAS. Yeah, we just recently had some training for our counselors from the OAS, UNICEF, to then eventually train some of our children to get to that place. So we are in process to get to the place where we can have. I can support my friend, I think is the name of the program. I can support my friend, yeah. So we're on the path.
Yes, and we also have the student council, part of democratic participation. And also I know recently a few of us went to Guatemala and we were talking about mentorship, a mentorship program. All of those stuffs are in the process of Grenada trying their best to create that policy that would help our students through a mentorship program and see what we can do.
In addition to that, the Drug Control Secretariat, in collaboration with the Inter-American Drug Abuse Control Commission of the OAS, we're looking at a program that is called SADD, Students Against Dangerous or Destructive Decisions. And there's a myriad of programs, but it's student-led, peer intervention, etc. With support from others, of course, but really SAD is a peer-led intervention program.
Okay, so I'm just going to try and summarize things that we have heard so far is that there is space for training as a particular area of focus. So whether that's in-service training, pre-service is not that well defined, but at least we can look at the in-service training. And the training then needs to be focused on more specific protocols, understanding referral pathways, sharing data back to the person who's making referrals. Sensitization when it comes to that, how do we get youth, children, adolescents to become part of that conversation? We said generally having protocols in place will help so that we know what the boundaries are and leverage the trust that is already existing with the educators to do a little bit more wherever you're being called upon by parents. PTAs is another opportunity that we could probably put in one of the action points. Is PTA then well attended or is that a space we'll have to activate? So should we put it? Should we not put it for now? Is something I'd wait for your comments around that. And we said life skills and HFLE can exist within the policy as of now, or we could just say life skills and other such programs because there are clearly more programs that are coming up, which are student-led, peer-led, which could have a component of mental health. So we'll try and then redo this bit and then share it back to you for comments, any concerns that you might have. Anything that I've missed which came up? Yeah. Yeah, of just making notes of the great suggestions. Okay, good. Anything else to add, Josh? Anyone else that we should be speaking to? Anyone we have missed out on? Because we curated your list quite thoughtfully so that we can get an understanding of what is happening. Are there enough programs that we've mentioned, spaces for collaboration? Anything that we've missed out on, please do let us know.
I think just to piggyback on something Mr. Strode shared, it would be very critical for us to, just by way of establishing a protocol, determine how information that is gathered by parents reasonably get back to the school. And of course, when we say the school, there would have to be, excuse me, levels of access so that not everybody will have access to the information, but for the child's comprehensive well-being, it is important for that information to be relayed to the school as well. So establishing such protocols, when we talk about the referral pathways, those should not be just unidirectional, one way, right?
And it doesn't have to be all of the information. It can come in it can come in the form that is applicable for who. I mean, and it may come in different forms. The counselor who may have to have direct would need to have more information than anybody else in the school. So it's just But yeah, thanks for bringing that up.
So it's almost like a multidisciplinary field. There's a
Yeah.
role for schools to play, there's a role for educators to play. What you can communicate to parents sometimes is far more acceptable than what a health professional might be trying to communicate to parents. Okay, that I think is helpful. Because that issue of the change has come up, wondering if you could, and might just give us some time to think of more things. Do you think we should ask the counselor with this as well? But or do you think that's well functional? But it's already pretty well functional. I like the
since there's a direct correlation between substance use and mental health issues, I think there should be a formalizing of a relationship, sort of a networking between Ministry of Mental Health. I mean, we support, we take part in some of the activities over the years, the Suicide Awareness Day walk and mental health, all of those. But I think there should be more of a coming together in a more strategic way. So I've already mentioned that. Yeah. Schools and community. So the Drug Control Secretariat has a 5-pillar sort of mandate. And in a nutshell, while you're waiting on the presentation, the first area is what, okay, I'm just waiting on Josh. Yeah, so our first area under the pillar is drug demand reduction, which is prevention and some aspect of treatment as well. Then we have what we call interagency collaboration and coordination. So we do quite a bit of that, engaging with local, regional, international organizations. And of course, institutional strengthening, where again speaks to collaboration among agencies, units, government departments, etc. Right, so incidentally, at the Drug Control Secretariat, we also collect drug-related information from hospitals and other prisons, etc., institutions in Grenada. And that information is shared for, like I said, policy and program development. So some of this information is fed into agencies like WHO and PAHO, the Inter-American Drug Abuse Control Commission, the European Center for Drugs and Crime, and all of these sort of agencies and organizations. So we also collect data from the Mungay institution and facility. And that data, again, is also shared. And that has been done for a very long time, since 1988 to now. So we collect the data. We have this, we call it an indicator, a form. We collect, as I said, admissions to the treatment, age, being aware of the dynamics and clients' privacy and all of that. We don't do names. We use unique identifier, etc. But we collect that data and then feed that data into local, regional, and international organizations. And I don't know if I'll have another opportunity, but I want to say this because, like I was telling Josh, in a meeting just last week or 2 weeks ago that I attended in Chile, the heading was treatment and recovery support. And I'm always very concerned as to probably more the social reintegration programs that we have. And if we could have probably better programs, that could probably help to eliminate some of the stigma and discrimination that clients are generally facing. So I found that meeting rather interesting as versus others I've gone to, in that we did quite a few field trips. And we got to see the whole, simple, non-complicated facilities that were created for youth, for women, for men with substance use or mental health disorders. And I think, I know you mentioned it, but I think we need to do a lot more as to even creating what I will call the equivalent of halfway housing facilities. And Dr. Chaitan, you remember the last time I was here? And I did state it, and I still mean it. It's my dream job to manage Grenada's first halfway house. A facility, the mental health policy should look into, like we say, and I know it does, treating people with adequate dignity and respect. And a fundamental need is housing, food, clothing, housing. And this halfway house could assist, may not be called that, with people, let's say people who virtually live on the street, but we're not taking away their human rights and we're not taking away their freedom, but they can come to this facility, get a hot meal in the morning, get a shower, get a change of clothes. I think we have to start looking into, if we're talking about adequately addressing the issue of mental health, we have to look at housing and all of those as well.
Yeah. So they put residential care.
That's what residential care, yes. and not confinement, not institutionalizing, but a place where they can access. Like I was saying to Josh as well, I know in our part of the world we don't speak about what we call harm reduction, but in some parts of the world, even substance users on the street can go to a specific place and get clean needles to reduce the harm of contracting diseases like hepatitis and HIV, etc. I know we're not there, we probably won't get there now, but at least we could at least have a space, a safe space where a person can walk in, get a meal. You know, we know they're on the street. Maybe one day, through with the interventions, we might be able to help them more. But at least that level of removing the discrimination and the stigma, at least providing them with a meal, at least provide them with a place to have a shower and some clean clothes.
Consultations. And it just struck me that, especially when it comes to education, because the Grand Bachelet Treatment Center, most of the students that go, most of the people that go there, are high school age, students, right? And I'm not sure. I mean, I hope we could, within the policy, could craft some where the mental health part of the rehabilitation is really looked at. Right now, it's basically if they have any criminal behavior or whatever it is, most times the court send them there, right? But probably many of them, it may have stemmed from some kind of a mental health issue, right? What we want to know is that facility equipped to handle that kind of stuff. And so I thought it would be really good to have the staff even be involved in here, where they could speak, like how education is speaking and saying, what are some of the lack, or what are some of the strengths? Wow, it's called the Grand Bachelet Juvenile Treatment and Rehabilitation Center. All right. So just as how we had the prison coming in, right, and collaborating with them, I think it's vital because these are young people. These are your students, really, right? It's the Ministry of Social Development that runs it, or National Security.
No.
Social Development. Yeah. Yeah, I think so.
Davin, could you? No. Could you let me in to the meeting? We're actually almost out of time for this. Hello. So, folks, there are some refreshments at the back. Even though we know it's almost lunchtime, there are fruits and such, which you can also have. No, we didn't take a break because you were so engaged and involved. But there are some fruits at the back that we'd want you to have before you leave. Okay. So what it is, it's just actually I think you would do that quite well. No, you. It's just an overview of the legislation. I think.
Oh, you're trying to do the legislation.
Just an overview.
Maybe you don't want to leave the
So I just would like to say thank you to my colleagues at the Ministry of Education. I am indeed happy to have you here because your voice, your dialogue, your discussion, your recommendations, we treat with those very highly. And whatever you are recommending, we know you are on the field and you are in the field with all of this. And there are some key persons that usually really support this ministry, and you know you are. We are happy for that. And we want you to get the vision that is silos work don't really make much sense in the ministries. It's about time persons realize it's a hand holding event that needs all aboard. So I'm very happy. I'm happy for Mr. Stroud is here, who has a very, let's give him a round of applause, who has a big part into this, drug avoidance and everything. We work together, and always feel free to call and say, PS, so. Even with I know we have some overlapping policies with your ministry also that, we want one-on-one. So I'm very happy for you coming out here today. We appreciate your presence and whatever discussion that was held. I'm very happy. So I know you'll be looking for the end results, which after we finish this will be we carried to cabinet to make sure that they can approve, and that from there it will go to the drafting unit of the Ministry of Legal Affairs, so that the amendments can be made to Cap 223 of the revised laws of Grenada, and that our policy will be approved. So thanks again, and we do look for further discussion in the future. Thanks.